Good afternoon all. I am Dr. Sabnis. Me and Dr. Kodkani, we are going to conduct this session on high tibial osteotomy. It's a big topic with a lot of interesting discussions happening in recent literature, and knee preservation is on the rise everywhere. So this is going to be a very good session that we are doing. There are talks from Dr. Sachin Tapasvi, myself, Dr. Kodkani, Dr. Mangal, Parihar, and Dr. Milind Chaudhary. So we're just waiting for 2 minutes for Dr. Tapasvi to arrive. I can see him. Yeah. So he's going to talk on the present status of osteotomies around the knee and recent advances. Dr. Tapasvi.
Thank you very much, Bhushan, and thank you, Pranjal. Thank you, organizers of WIROC. I'll be speaking today on modern knee osteotomy, basically giving just an insight into what the next couple of talks are to be. So essentially, if you look at what we were and what we are, I think pre-2000 era was all about performing this type of a Coventry type of an osteotomy, where we predominantly did lateral closing wedge osteotomies for osteoarthritis based on simple weight-bearing X-rays, and used a calculation that 1 millimeter was 1 degree of correction. It was all visual, and we had fixation with implants which were very flimsy and only plasters. What we ended up with was basically oblique joint lines, and we tended to put the knee in valgus, which then later on progressed, and a lot of patients ended up with a valgus knee with a medial compartment osteoarthritis. So fast forward to 2023, where do we stand today? Essentially, the whole concept of modern osteotomy is all about joint preservations, and we look at these three main indications, which is predominantly malunited intra-articular fractures, neglected ligament disruptions, and even medial compartment arthritis still stands today. We're trying to achieve good correction both in the coronal and the sagittal plane. The sagittal plane is something that we understand a lot more better now, and we want to try and realign any form of malalignment which is present in both of these planes to achieve a good stable function of our knee joint. So essentially, modern osteotomy has looked at four main indications, which are besides the indications of the medial compartment arthritis. So we're looking at realigning the lower limb when we're trying to correct cartilage defects, and the reason being is that we need to restore normal alignment in when we're treating chondral lesions, because if you do not align your limb and leave a malaligned limb and treat cartilage, it is going to fail, which is something that we understand more and more now. Also, what is important to understand is that we need to look at the osteotomy to help realign the limb in someone who has chronic ligament laxity. So whenever we're looking at X-rays like these, this is a 55-year-old physician who had a valgus knee, in whom the deformity was essentially in the tibia. He presented following a chronic MCL tear along with an ACL tear. And these are his images. You can see that his MCL is lax, his meniscus is extruded, and if you leave someone who is 55 with such type of a problem, then I think it is a sure shot recipe that he is going to land up with an early knee replacement. And once you look at problems like these, you need to restore their knee stability back to normal, and which is when what you want to do is that you want to realign the limb, reconstruct the ligaments so that his function can stay good and stable for the next couple of years and next decade, so that he does not land up with early arthroplasty. So essentially, again, going back to the drawing board, you need to understand where the deformity is, and he had a closing wedge osteotomy on the tibia along with a concomitant MCL, ACL reconstruction and meniscus repair to do everything for him to restore his normal stability and his normal function so that he achieves a good long-term outcome. Similarly, in the sagittal plane, we are very well versed now that if we have an increased slope of the tibia, then it leads to attritional tear of the ACL, and if there is a problem which is reverse, it may lead to problems for the PCL. So we now on lateral films will calculate the tibial slope, and if there's an abnormal tibial slope, we want to go ahead and plan our corrections with the help of software techniques and do an anterior closing wedge osteotomy, which is something that is extremely important for us to look in terms of restoring the abnormal anterior tibial translation, which allows for a good outcome. The meniscus, if you repair it, I think it's again very critical to look at the alignment. So here is someone with a radial tear of the medial meniscus with chondral wear, and you have to recreate his geometry and get everything properly aligned. And so is the same that holds true when we're looking at malunited tibial head fractures, which need to be restored again using the proper planning methods. And this particular lady here required combined restoration of her articular surface with a bone graft and recreation of her geometry using a lateral closing wedge. So to conclude, we need to have better understanding of deformity in today's world. Not all valgus is in the femur, not all varus is in the tibia. We have to correct where the deformity is and not land up with x-rays in which the limb looks straight, but everything is all over the place. Because if you have an abnormal joint line orientation, you have a higher chance of failure of your procedure. We need to recognize any form of sagittal plane deformities, and these expanded indications for modern osteotomy pave the way for knee preservation is what we need to look into.
After that great talk, we'll just talk a bit about the basic surgical steps of a high tibial osteotomy. And the short video presentation, I'll try and squeeze the whole osteotomy process of normal 40 minutes into 7 minutes. So please bear with me. So the first thing before any osteotomy, before the patient comes to theatre, is a planning. You get a good looking scanogram which is properly aligned with the patellar facing forward. And then you plan your deformity correction using any of the techniques you want to use. You can use a software planning, you can use paper pen planning, whichever way. You should know before you take the patient to theatre what amount of correction you are going to do and which bone you are going to correct. So there will be a few tips when I show the videos. So the first thing you do is draw your markings. So tibial tubercle, proximal end of the tibia, medial tibial plateau, the anterior shin line or the anterior tibial cortex and the posterior tibial cortex. That's the normal incision that you're going to take for your HTO as such. EUA normally shows a lot of correctability of the deformity, and based on that you decide whether you need to release the MCL completely or partially, depending on the severity of the deformity as such. So the incision is a straightforward straight line incision. There are people who do smaller incision, there are people who do oblique incisions. I've even seen transverse incisions as well. But this makes it easy because you can convert it in future as and when the patient needs a total knee replacement. This can be included in the same incision as such. So a standard incision to expose the medial side of the tibia. The dissection is fairly straightforward. You locate the medial wall of the patellar tendon, you feel the pes fascia and then open it in a L-shaped manner such as this. And all of us are very careful or very accustomed to peeling off the periosteum on the medial side, and it literally peels off very easily. So in an L-shaped cut, just peel off the periosteum like you would on a fracture end, and that is done all the way to the posterior end. Once you reach the posteromedial part of the tibia, you will get two layers of the pes fascia. The deeper layer is the MCL. You can see the MCL coming in picture there. Now, MCL can be released completely without any worry, but I usually believe in selective release of MCL. So the deformity is uncorrectable, you will need to do more release. The deformity is correctable, not whole MCL needs to be released, but that MCL is being released as we speak now using a cautery, and rather than cutting it transversely, I like to release it vertically so it has more space to heal back onto the field of area. This is the most important step during the whole surgery. Putting a big, nice, robust periosteum elevator and scratching the back of the tibia all the way to the lateral side. And you should be hitting the fibula head all the way down. So if you have done this, half of your worries of injuring neurovascular bundles are over. And you're able to get to the back of the tibia really well. This is generally followed by placing a big Homan on the back of the tibia. This is going to help you in preventing any injury to the neurovascular structures. That will stay during the surgery there. You can put the plate on top. Make sure you got sufficient space for your osteotomy. There are various plates available now, so this is always a very useful step to mark where your osteotomy is going to be. That makes life much easier. Then you put two parallel K-wires or guide wires from medial to lateral, starting about 3.5 to 4 centimeters from the medial joint line, aiming for the lateral side fibula head. or you can go 1.5 centimeters from the lateral joint line. So exactly like that. As you can see, you have sufficient space for the plate to be fixed, and this is the reason you need to put the plate on before you start the osteotomy to make sure you got sufficient space for the osteotomy. Make sure that your saw goes parallel to the K-wires or the guide wires. I tend to bend the wires proximally and try and cut on the wire. So my blade is always hitting the wires and is being guided by the K-wires, so that I'm not going in the joint or I'm not deviating away from my osteotomy site that is planned. So you can see the K-wires going in. Fast. Okay. This is followed by a biplanar cut, which is about 100 degrees or 110 degrees at an angle to the transverse cut, and that's elevating the patellar tendon up, and that is how a transverse cut, oblique cut is done. This is called proximal biplane. That's how you will get your osteotomy. Once you've done that, you need to stack in osteotomes, which will open the osteotomy in such a way that your hinge will remain intact, and you can play with your osteotomy to see if you are able to maintain the hinge. Sometimes you put a hinge pin such as this and make sure that your hinge is intact and you're opening and closing the osteotomy under vision without worrying about hinge breaking or any untoward effect happening. If you've done a good job, you will see the osteotomy opening and closing nicely just by moving the foot like that. Then you put a laminar spreader, decide the amount of correction you want to do, and check your alignment. Make sure you are on the lateral tibial spine. I'll take 30 seconds more. Lateral tibial spine. Then you fix the plate as standard. So plate is fixed in a standard way. There are 4 screws proximally, 4 distally, and that's the end picture of your osteotomy, fixed securely with a plate. And you can see the normal valgus, you can see the normal valgus alignment of the knee post osteotomy. That's the post-op X-ray, and that's the patient 6 weeks down the line, walking more or less comfortably without any issues as such. So that's roughly how you can do HTO in 7 minutes. Thank you.
Good afternoon. Now, coming to dome osteotomy of tibia for treating the tibia vara. Well, medial opening wedge osteotomy with an internal fixation device, as we've seen earlier, is the most commonly used option, and it's quite popular because it has a number of advantages. No fibular osteotomy being required. It's quite a simple and straightforward procedure, allows for a stable fixation, early mobilization, and if you need to alter the tibial slope for managing the ligament deficiencies, that is possible using this procedure. But it does have some drawbacks. We cannot alter the correction in the postoperative period. So whatever correction you've achieved intraoperatively, you need to accept it in the postoperative period. That's irrespective of whether you've got it correct or not. The patellofemoral joint is not addressed to. For higher degrees of correction, you may need to vary your technique of the osteotomy. And if the graft, the gap is too large, one may need to graft that gap. No rotational corrections are possible. Implant-related complications may occur, and if you need to do a graft harvesting, a hamstring graft harvesting, it would be difficult following this fixation. There is always a risk of hinge fracture, delayed unions, non-unions. It's not a midline incision that we do the procedure through, and for larger corrections, there may be an issue with limb lengthening. So the dome osteotomy with the dome stabilizer overcomes all these drawbacks of the medial opening wedge osteotomy with an internal fixation device. So in our practice, it may be best to have both these options available at hand, as each of these would have a different set of best suited indications. The osteotomy selection could depend upon the degree of correction that we need to achieve. For larger degrees of correction, maybe a dome osteotomy is preferable. Those patients having patellofemoral symptoms, again, a dome osteotomy, since we can get the Mackay effect. Rotational corrections are possible with a dome osteotomy, but the patient's compliance with an external fixation device needs to be taken into consideration. For those patients having osteopenia, diabetes, or ligament deficiencies which we need to manage by increasing or decreasing the slope, one may opt for a medial opening wedge osteotomy. Now, the dome osteotomy itself has a number of advantages. It can be done through a small midline incision. It is in the metaphyseal bone stock area of the tibia, so good chances of union. There is no limb length discrepancy. Rotational corrections are possible. There is no patella infera since we mobilize these patients much faster and there is no distalization of the tuberosity. Anteromedialization of the tuberosity is possible, so the patient gets relieved of his anterior knee pain. Much higher degrees of correction are possible, and precise correction of angulation is possible because the fixator allows us to alter the correction even in the postoperative period. Now, when we are considering a dome osteotomy, we see that the ACA of the osteotomy precisely coincides with the cora of the deformity of tibia, and therefore postoperatively we do not get any secondary deformities. I prefer to fix this with this simple uniplanar bilateral fixator, and this has been published in the American Journal of Knee Surgery. I call it the dome stabilizer. The dome stabilizer clamp has got two blocks, the sliding block and the swivel block, and each of these function independently and can be locked independently so as to get a static frame as and when necessary. As you can see, the fixator is quite versatile and we can keep both the pins at an angle to each other, both in the coronal plane as well as in the axial plane, much unlike your Chanley's clamps, and this is what allows us to get rotational corrections as well as postoperative alterations in correction. Now coming to the procedure itself, that's the preoperative planning, that's the preoperative mechanical axis, postoperative mechanical axis, the ACA of the osteotomy, and therefore that is the degree of correction that we plan for. First, a fibular osteotomy is done with excision of 1 centimeter of fibula. The proximal pin is then passed just 5 millimeters below the subchondral bone, parallel to the tibial plateau. This is done under Siam guidance. The distal pin is then passed at the angle of predetermined correction, what we've done in a preoperative planning, to the proximal pin. The midline incision, proximal end of tibia exposed, and using this simple device, we can use multiple drill holes in a dome-shaped fashion in an anteroposterior direction proximal to the tibial tuberosity. Once that is done, we use a narrow 5 millimeter osteotome and just unite these holes together to complete the entire osteotomy. Acute correction is then achieved on table till both the pins are parallel to each other, and we assume that the degree of correction we've planned for is achieved. The external fixator is then applied with the lateral strut, first in the compression mode and then the medial strut. As you can see, this osteotomy has a huge surface area for union, and therefore union is not an issue. The fibula, which is harvested, is then split vertically into 3 and is grafted at the site of truncation, and that is the final picture following the osteotomy. That's the immediate postoperative X-ray. Now in the postoperative period, one can do a scanogram and check for the degree of alignment that we've got. For any reason, if you've got an improper degree of correction, as in this particular case, all we need to do is relieve the compression over the clamps. The side requiring distraction is then distracted first to disimpact the osteotomy and alter the degree of correction, and then re-impact back again by compressing on either sides to achieve our final desired degree of correction. For example, in this case, you can see immediate post-operatively, this is an over correction, despite both the pins being parallel to each other. But using the versatility of the fixator, we could still alter the correction in the post-operative period to get the precise degree of correction that we planned for. So we start with full range of motion by around day 2 or day 3, and we ask the patient to full weight bear as early as possible. They are mobilized from the 3rd day, and by 2 weeks, they usually would leave their walker and walk full weight bearing. By 3 weeks, they are climbing and descending stairs quite comfortably. They can sit comfortably cross-legged because the fixator is quite compact. Even wearing regular clothes is not difficult because, again, the fixator is compact. Here you can see there is a significant difference in this particular patient's gait following the surgical procedure, both on level walking as well as on stair climbing. That was his X-ray preoperatively, immediate post-operatively, and X-ray at the final follow-up. So by around 10 weeks to 2 months, the osteotomy unites and we remove the entire fixator, so there are no implants post-operatively. So it's best to have both these options available at our hand since it covers a more wider range of indications, and therefore we can ensure more better results to all our patients. Thank you all for your attention.
पाँच पे घंटी मत बजा, 7 minutes. Right. So same message, different tool. All of us who do HTO in different ways are convinced that the long-term results of HTO are good. We want to get 183 to 186. Nowadays, there's a tendency towards going towards a slightly lower number, but we want to get it accurate as far as possible. Now, the question is, how accurate is the frontal and sagittal plane correction with an open wedge high tibial osteotomy? Earlier, in at least about 50% of the cases, the mechanical axis was not in the exactly desired position. So if you look at this review by BEMT, the yellow shows you the targeted angle and the blue shows you what was the range of accuracy. And what basically this graph shows is that though the targeted angle is narrow, what they were able to achieve is fairly wide. So you are not able to get it as accurate as you would like. And what they said was the results of this review stress the importance of ongoing efforts to improve correction accuracy in modern HTO. So here's a case. I do largely fixator assisted or fixator HTOs, but I do use the plate. And the biggest sort of issue I have is in terms of assuring the accuracy. So this is the X-ray on presentation with significant varus. We do the full length X-ray planning with the Miniachi method. The green line is the future mechanical axis and the yellow angle that you see is the angle of correction. Intra-op, I check the alignment just as everybody else checks with the alignment rod, not the cautery cord, applying axial pressure to simulate weight bearing, aiming for the base of the lateral tibial spine. But weight bearing changes alignment. So on table, I had a good alignment. The moment this patient is weight bearing, it's obvious that she's in excessive valgus. Patient is fine. However, many a time these patients are not very comfortable with the excessive valgus, and the other issue is of overcorrection. Will there be lateral wear or not? And the problem is, especially with this JLCA, when you have a JLCA, this is on the left you see a varus view, on the right you see a valgus view. That variation in the soft tissue tension is what creates the trouble. So I use a fixator, a similar distal to tibial osteotomy, but not complete, same aiming for the tip of the fibula like all the others. This is the difference between the open wedge done with a tomofix, that is the blue line where there is a biplanar, and the way I do it slightly below the tuberosity but still an oblique osteotomy, and we get an osteotomy which is complete enough to manipulate easily, but still the hinge is intact on the lateral side so that even the fixator on the medial side is stable enough. So the distraction begins after 7 days, and usually it's completed in about 21 to 24 days. The patient turns at about 1 millimeter per day, and by the principles of Elizarov, this gradually will correct that deformity. So here's the pre-op plan. The angle of correction is 13 degrees. The HKA is 170. There are newer methods of taking the JLCA into account, and in this planning, we've done that. We've taken the JLCA into account, and by that, we get 21 days of distraction. However, after 21 days of distraction, we find that the angle has, the femur has kind of tipped over and gone into extreme valgus. That is with a distraction of only 17 mm. But because we have the fixator, we are able to compress it because the fixator allows for adjustment. So with 4 days of compression, I'm able to get the HKA to the desired range of 185 to 185.5 degrees. Right? So post fixator removal, the fixator was locked at 185. So similarly, if it was under corrected, we just have to do a few days of distraction more, and we can always get into that ballpark of 183 to 186. Now, if you look at the accuracy of correction, this is a paper by Bachal et al., where they were able to achieve the desired alignment in 84% of the knees. Okay, we are still not at 100%, but this is way beyond that. Similarly, we looked at our patients by one of my students from JJ. We wanted to achieve this 183 to 186, and we were also able to achieve it 80%. We could go higher, but there are some issues where sometimes we choose to go more than the angle where the weight-bearing axis goes. So out of this, we had under correction in 3 patients and over correction in another 3 patients. So in conclusion, my reason for using the fixator is because for me the fixator allows for practically infinite adjustment after the surgery in a weight-bearing position, because I can do that full weight-bearing position at the end of that correction and see what exactly is happening. And for me, it's a question of 80% accuracy versus 50% accuracy. And till now, whatever we know is that the accuracy is equal to longevity of the result. Thank you.
That was a great talk, Dr. Parihar. Now I call upon Dr. Milind Chaudhary. What you have seen is all basic osteotomy. Let's go into the domain of complex osteotomies around the knee. And Dr. Chaudhary is an expert in that.
Hi, good evening, Mr. Chairperson, Bhushan and Sachin, and teachers in the hall, Ram and Professor Modi. Thank you very much for your kind invitation and having me participate in this session. We are going to look at some of the newer concepts and a little delve deeper into high tibial osteotomy. 90 to 100% of the literature is on open wedge high tibial osteotomies, as you may have seen, and some domes. But medial compartment osteoarthritis comes in different shapes and sizes, more deformities, gradually increasing. When you look at the mechanical axis, there's more and more deviations. So therefore, the question to ask, can one osteotomy cure all? We evaluate the deformities with the MPTA, MLDFA, JLCA, CPA, and also we need to evaluate leg length discrepancy and limb rotation. So one HTO cannot solve all these problems without creating new ones. We've been trying 6 different osteotomies for the last 31 years, and based during the COVID period of more than 15,000 measurements, we've come up with this algorithm I'll share with you. You choose the HTO based on the location and severity of the deformity. You break them up into tibial, femoral, intra-articular, or hidden. The tibial deformity may be small, which is when your medial opening wedge or a closing wedge is appropriate. If it's a small deformity, but there is an intra-articular component, you do the TCVO. If it's a large tibial deformity, you can do the focal dome if it doesn't have an intra-articular component. Femoral deformity well beyond 90 to 93 degrees is really when you should be thinking about DFO. And you choose it only in those cases. Now the intra-articular deformity, I'll come to it briefly, could be in the sagittal or the coronal plane. If it's in the sagittal plane, you do the focal dome, and if it's a hidden deformity like the length and rotation is when you add the focal dome deformity. So this is the entire algorithm. And based on that, we are going to now look at complex deformities. The postulate till to date has been only alignment is most important. But what the mind doesn't know, the eye cannot see. Well, obviously what the eye can see is this lateral thrust and this sort of mediolateral laxity which can be recorded under the C-arm. So this is a sure giveaway for an intra-articular deformity. There are some studies that led to this understanding. The first study we did with 4 observers, 118 limbs, and we broke up the mechanical axis into greater than or less than 10% of joint width. And what we found is that larger deformities correlated well with a high JLCA. In the second study, done after 3 years after the first, 141 limbs, we broke up We kept mechanical axis deviation at 0%, and half of them were more than 0, half were less than 0, which are severe. And we found that the larger deformity is correlated with CPA, the condylar plateau angle, which tells you that the two condyles are not collinear. So we have to give credit to Tsukasa Terumoto and his team, which started in Nagasaki with Professor Chiba, who discovered the tibial condylar valgus osteotomy. The literature on this is scarce. We had the privilege of hosting his article in the JLLR in the year 2015, and there are just a few more articles in English. The principle of the TCVO is as follows. It is based on a high JLCA and a CPA. There is a teeter-totter and a point contact of the medial condyle. So the contact area is reduced. So first we elevate the condyle, that reduces the teeter-totter, it broadens the surface area and therefore gives relief from pain. But the mechanical axis may not cross 50%. So here are some examples. This lady in her mid-50s, like so, and her the joint becomes congruous. The end point of this surgery is when there's no more mediolateral laxity and the lateral and the medial tibial condyles make simultaneous contact with the medial and lateral femoral condyles. So this is the intra-articular. This is how it looks when it heals. A very brief look at the surgical technique. Large incision, patellar retinacular releases. This is very careful drilling of the posterior cortex and cutting of the posterior cortex. And very careful bare entry into the intercondylar area. Obviously done gingerly and with great care. And then we elevate the medial condyle. Like so, we ensure it doesn't spread apart too much, till both the condyles make simultaneous contact. And then we plate it. Just a couple of look at some of these deformities. This lady came to us with this horrendous inability to walk more than a couple of feet, and these are her deformities in both the planes. On the right side, she had no mediolateral laxity. So therefore, she got a fixator-assisted plating of her dome. It's an extra-articular osteotomy in which we corrected the FFD by reducing the slope, by increasing the PPTA. Then on the right side, he gets this TCVO surgery. At the end of both of these, he can walk very nicely and for any number of kilometers and has no pain whatsoever. Similarly, an elderly lady like so, just the TCVO doesn't correct beyond neutral. So we are worried about the undercorrection and we decide to add a second osteotomy. When do you add the second? There are many formulae for this. The alpha 60 is the angle that you need to correct the mechanical axis to the Fujisawa. That may be alpha 62 or alpha 60, or you choose alpha 55 or alpha 54. You have to choose the alignment. So it's not one size, one alignment fits all. And then you do your varus and valgus JLCA. The varus JLCA is positive sign, the valgus JLCA is a negative sign. So varus plus valgus multiplied by 1.5. And if this angle beta is greater than, then you need a second osteotomy, okay? That's when you do it. So we tried multiple things. We added a second closing wedge osteotomy in the same plate. Does manage to correct reasonably well in this lady. This is what we did in the second instance. It doesn't look beautiful, but she has zero pain 6 years down the line. And then we chose to add, this is what somebody Kuwashima wrote, we add a second osteotomy like this. But it doesn't work well. So if you're really stuck on alignment, then we can't afford to undercorrect the mechanical axis. And this animation shows what we do is first we open the joint, we correct the joint, and it gives us up to 45. And then what we do is we add a second osteotomy below this with the fixator, a nice dome osteotomy which enables you to correct to your heart's extent, like so. And somebody with this lateral thrust and large deformity with the pagoda tibia, you can correct this very nicely, stop when you want, watch them walking until you are very satisfied that you've hit the target both with the intra-articular as well as the extra-articular osteotomies, like so. So now we got good results with the JLCA, with the CPA, and the mechanical axis with the combined osteotomies. But I'll wind up rather soon. Yeah, so the theorem is that, remember, primary theorem is that congruent contact of the bony ends and instability. So there's a different theory going along, and it's no longer just alignment. You have to understand that it's instability of the joint. And if you look for it, you'll find it more and more and more in most of your patients. So the TCVO alone modestly corrects the mechanical axis, adequately corrects the intra-articular elements like the CPA and JLCA, but doesn't overcorrect the MPTA. You don't want to go beyond 95 degrees MPTA. Okay, and it doesn't correct your tertiary deformities, and it doesn't correct beyond 50%. So when you add the extra-articular with a fixator like this, I could go up to almost 60% as a mean and correct this. And we could also correct rotation from the distal osteotomy. You can correct length, which I have done in several instances. We have shortened some TBA along with an intra-articular correction. Now, what if you want to have your cake and eat it too? Here comes focal dome condylar osteotomy. An elegant two-in-one option came from Kanazawa City, again Japan. Professor Suchiya, Igarashi and Suchiya. Here, the osteotomy is a little different. The vertical limb of the osteotomy is lateral to the patellar ligament. And then you correct it in such a way that through the single osteotomy, you are able to correct both the intra-articular and the extra-articular components. 72-year-old physician with a large mechanic, -5 MAD, and this, she needs a 16-degree correction, so she's not a candidate for an opening wedge. And now I don't want to do a fixator for a 72-year-old. This is a varus valgus JLCA. So, the 12 degrees is, lesser than the 16, so she needs a second osteotomy. So these are the steps. I always do a patellofemoral retinacular release. This is a simple jig. The first vertical cut is outlined, then is the semicircular cut. You use these lateral cortex protection wires because you're too darn close to the lateral cortex. Yeah, with your heart in your mouth, you do this sometimes so that you don't fracture it, and then you create this osteotomy to give a good correction. No deviation, gross deviation of the joint line, as well as a good correction. In a similar case like this, you can see how nicely there is a congruent contact at the osteotomy site as well. It was written up in JLLR, the first 10 cases, we have now crossed 20, and there's exciting times ahead. Thank you again very much for your kind invitation.
Very interesting and very complicated talk. Thank you. Any questions from the floor? Anyone wants to ask any questions?
I'm Dr. Jethwa from Ahmedabad. I want to ask about the consideration of the flexion deformity. Patient is having a fixed flexion deformity of 10 degree. What will it change when you go for a upper tibial osteotomy? And is the calculation changes, or you do not give attention to that, or is the both cases similar? One case is having no fixed flexion deformity, other is having. That is the first question. And the second question, that do we know by now why so many patients are having a severe tibia varus deformity? They don't get arthritis. Is there anything which is explained in literature?
Tibia vara without osteoarthritis, I think, is a question of time. There are patients who will get it by 35, 45, and there are patients who will get it by the age of 70, which is isolated medial compartment arthritis. But I think all patients, there was a study long ago which showed that 98% of patients with varus, once they develop arthritic changes, will continue to progress. So yes, you don't need to do necessarily a prophylactic correction. I mean, there are younger patients, we will do it for cosmetic reasons. But other patients, you don't need to do it until and unless they develop pain. Second question was, what do you do when there is a flexion deformity? I think all of us will try to correct that flexion deformity. There is a bunch of patients who, with therapy, will improve their flexion. Okay, so the amount of flexion that you need to dial into your correction will be less.
My point is, like when we correct varus,
Yes.
we go from medial to lateral.
Yes.
When we correct flexion deformity by some sort of a recurvatum,
Yes.
we shift weight from posterior to anterior.
No, but we can, at the most, we can level the plateau. From an 80-degree slope, you can make it up to 90. I know there are people who will go into this. I don't agree with that because you talk of an oblique joint line in terms of the coronal and say that the oblique joint line can cause shear and therefore problem. Similarly, if you cause recurvatum in the sagittal, it can slide forward or slide backward. More slope, it will slide back. Recurvatum, it will slide forward. So if you have to correct your slope with an osteotomy, I think you have to go to 90 degrees on the tibia and the remaining has to be done femoral.
May I just add to that? There's one more point you need to consider for this flexion deformity is intra-articular osteophytes. Sometimes you have these anvil osteophytes inside which would block your extensions. So more often than not, we always perform an arthroscopy. Excise the osteophyte and you would get certain amount of extension. At times, ACL mucoid degenerations also would cause flexion deformities. So treating that part of it would again negate the deformity. Third point is when you're doing a posteromedial release, that itself would add to getting the extension to some extent. In addition to that, of course, you adjust the flexion deformity in the osteotomy.
See, sorry.
Yeah, go on. Ram, after you, we'll ask.
Okay, so in this varus correction, we are correcting in the AP direction. I feel that it's a three-dimensional deformity of tibia varus. I mean, we don't make any special efforts to correct that rotation. That's the reason why I find that some of the HTOs or which have been done from the media side, they have done exceptionally well, but some of them don't do as well as others. So is it the rotational component that we are not looking at, which we are trying to not correct in the AP, that we need to look into?
We are looking at, I think all of us are looking at rotational deformity in terms of putting them prone, looking at the thigh-foot axis, etc. If there is a significant or there is a clear or you're worried about a rotational, you can do a CT rotational profile. In that particular situation, yes, you can correct the rotation, but I don't agree with the older notion that every tibial osteotomy you should include an external rotation.
No, that is right. I agree with you. But, I mean, are the analysts looking into that rotational element when we are correcting this?
Most of us do look at
or it just happens
It goes beyond,
inadvertently.
it goes beyond the rotation as well. More than 30 years ago, Andriachi wrote a paper explaining this. It's the gait factors. There are many factors at play here. It's not just the rotation. Why do, he found out this high adduction moment arm gait. An evaluation of an osteoarthritic patient is not complete unless you see him walking. You don't necessarily need a sophisticated gait lab. You can observe the dynamic varus or the lateral thrust component. And he found that you can train. We train our patients. You can either correct it surgically by externally rotating or by overcorrecting the varus, or you can train them, take shorter steps by out-toeing and by knee flexion at heel strike. So the gait is important, and there are many other factors. It's not just, it's multifactorial, like you said.
So you asked essentially, is there a component of rotation?
No. I know that there is a component of rotation. Are all the panelists looking into it when you are correcting, or it is just inadvertently gets corrected?
No, I think the answer is yes. We look for it. If there is a deformity, we will try to factor.
So you do a CT rotatory CT scan?
Not always. We will check it with clinical. Clinically, if there is no gross rotation, then we would not. You agree, everyone?
Yes.
Last question, ma'am.
Thank you.
Yeah. Good evening. I'm Dr. Neha Godkani from Nagpur. My question is, in cases of primary ACL reconstruction, do you always measure the slope, posterior slope of the tibia, and if at all it is more, do you correct it then and there, or you restrict it to revision cases? And
Okay, so I think I'll take that question. The scenario here is that, yes, the high posterior slope is definitely a modifiable cause to prevent ACL failure. If the slope is extremely high, more than 18 degrees, then in that very rare situation, one would do a primary slope correction along with the primary ACL. But for majority of cases, more than 95%, I think we restrict it only when your ACL reconstruction fails. For those odd cases in which the slope is high, then we try and decrease our failure rate by adding an extra-articular tenoid assist kind of procedure.
Dr. Modi, last please.
Yeah, this is for Milind. When you do a intra-articular osteotomy, does your osteotomy go medial to the tibial tubercle and the tendon of patella, or does it go lateral? And second, do you do the osteotomy and drilling in flex position of the knee to prevent injury to the posterior structures, or you do it in extension?
I'll take the second one first. There was a study that showed that flexion doesn't protect the posterior neurovascular structures, that there is an anterior branch that goes close to the bone and it tethers the popliteal artery very close to the tibia and it doesn't change flexion. So I do not use flexion. I know that you are a proponent and that's how you protect it. I find it rather difficult to keep my orientation with the knee in flexion. How to do, angulate the osteotomy, etc. And the TCVO, the vertical cut goes medial to the ligament, and in the FDCO, it goes lateral to the patella.
And what happens to the insertion of the ACL?
So we do not breach the intercondylar part. Don't damage the ACL.
Thank you, sir. No more questions because we have run out of time. And I thank the panel here for a wonderful session.